stability. But as the days goes on regarding the evolution of a stability training, we move our perspective in terms of segmental stabilization. Again, in 2000, we move our perspective in terms of core stability. And now people are more deep dive into the motor control exercise. Though spine stability is also important, segmental stability is also important, core stability is also important. It is not about just you should focus on motor control. Before implementing the motor control exercise, you have to pass from these three categories. Directly, you cannot improve the motor control. You require a proper range of motion. You require a proper muscle training. So now, which is the best one? The strength or a control? It is also the hot topic. Strength is also important, and the control. If the person doesn't have a good control, so he doesn't have a good strength. If he has a good strength, it is not about the person must have a good control. So both are interconnected with each other. There has to be a strength, there has to be a good control. When the person has a good control, the person has an adequate amount of strength in his limb or in his routine activity, where he or she won't find any fatigueness in their routine task. So दोनों को इक्वल इंपॉर्टेंस है, लेकिन स्ट्रेंथ शुरू करने से पहले जॉइंट का आपको कंट्रोल डेवलप करना पड़ेगा. फॉर इंप्रूविंग द कंट्रोल यू रिक्वायर द प्रॉपर मोबिलिटी. सो एज सून एज यू गेट द मोबिलिटी, यू शुड इंप्लीमेंट द स्टेबिलिटी एज वेल एज द स्ट्रेंथनिंग पार्ट. And eventually that will guide you to improve your patient's control. Many of times you must have noticed in your patient that like an example of a knee joint, when he or she starts knee flexion exercise, okay, knee flexion exercise, their knees goes into the adduction. Sometimes they don't know how to bend their knees, because there is a proprioception deficit. As soon as we improve the mobility of a knee joint, the persons change their behavior regarding the movement pattern. So once we get the good control, then we can add up a good strength, because for improving the strength, we require a good amount of external load. Without control, if you add a load to the limb, the person is not able to complete the range of motion. But what is wrong with this question? The low back pain is a symptom, it is not a disease. So when the patient comes to your doorstep and he or she says that I have a back pain, find out what is the cause. Our human body moves into the 3-dimension way. Why this person develops the back pain? You should ask about the history. Many of times you listen from your patient that since 2 or 3 days I had a back pain. Since 1 month I had a back pain. There is no radiating. There is no referred type of pain. The pain is not going till the knee joint. Like the questions that like the answers they will give you. But when your patient complains the low back pain, think about the proximal part and think about the distal part. You should deep dive into the patient's routine activity. What's the patient's occupation? Every day, which movement is more the person is indulging into that? Like let's take an example of homemaker. She has to do overhead activity more than 50 times in a day. So it is about the extension pattern. The servant, he has to bend more than 50 times in a day, forward bending. And he comes to our clinic with the back pain. So we have to think that flexor muscles are too much working. Extensor are not efficient to make the spine in a neutral position. So if we understand about the cause, then it is very easy for us to treat the back pain. For SIJ pain, referred pain till the L4, L5. Once you have abolished the L4, L5 pain, the person starts complaining at the pain at the SIJ. So now we think that the person doesn't know where he has a pain. Sometimes we blindly give the label, he's a psycho patient. No, it is not like that. Where the person has a more perception of a brain, a perception of a painful area in his brain that he reflects in front of us. So back pain is not a symptoms. Back pain is a symptoms. It is not the disease. We see these three type of patient in our clinical setting. The one left-hand side is central pain. The right one, sciatica pain. It is a radiculopathy, tingling, numbness. And the last picture, it's a referred pain. So we have to distinguish our patient whether the person has a radiculopathy or a referred pain. In most of the healthcare professional, they give the referred pain, they give the label referred pain as a radiculopathy. But actually, they have a referred pain. Sometimes the person has a gluteal muscle trigger point. So they have a referred pain till mid part of the thigh. Sometimes they have a SIJ pain, and SIJ pain can refer till the knee joint. Sometimes this pain can refer till the lateral aspect of the ankle joint because the whole system is get affected. Those who have radiculopathy, they have a tingling type of sensation in a walking or in a certain position. They don't demonstrate a referred type of pain. they वो स्पेसिफिकली आपको सिंगल लाइन के थ्रू ही दिखाएगा, जैसे कि along the dermatome they will show the pain pattern, tingling pattern along the dermatome course. So that is the clear indication the person has a radiculopathy. And the referred pain, they will show that I have a pain at this region or at this region or all over the lumbar area. So the referred pain, radiculopathy, and central pain, that you have to distinguish. And you can also find managing radicular pain on the application. So you can go through it and read it. On the other side, the referred pain and radiculopathy. The radiculopathy pain is not getting abolished by changing the position or by using some technique. In most of the cases, like the person has a severe stenosis, when he walks more than 20 meters, he starts complaining of tingling type of pain. But in referred pain, once you clear the trigger point or once you improve the mobility of SIG or L4, L5 region, the person has abolished or the person has a reduction in his pain. So these three things we should understand. On the other side, we know the radiculopathy, we know the referred pain, we know the central type of pain. But on the top of that, we need to identify the pattern. When we walk, when we run, and when we throw, in all these three activities, the human body moves in a transverse plane, sagittal plane, as well as the frontal plane. But if the person is complaining of pain from getting out of the car, that clearly indicates that the person has a rotational issue. Human body moves in the sagittal plane, but the back pain occurs in a transverse plane. Now you have a question in your mind, how it becomes the transverse plane issue in the back pain. The sagittal plane starts with the transverse plane. Like when you start walking, your hand drives the heel strike pattern. So what will happen? Your body is rotating. Rotation followed by the flexion of the hip joint, knee joint, as well as the ankle joint. But we move in the sagittal plane direction. That's why we call the human body moves in a sagittal plane. But the sagittal plane the sagittal plane is influenced by the transverse plane movement. So if we understand deeply with the movement pattern, that will guide us how we need to target the specific area. The person complains of pain while running. So in that scenario, we have to look from the lumbar spine as well as the pelvic joint point of view, whether the person is walking with the excessive lumbar curvature in a kyphotic posture. What about the hip flexion? What about the knee extension? What about the ankle dorsiflexion? All these three things are very much important aspect. This we talk about the functional activity. Now we talk about some specific type of, or I called it as a typical complaint of a back pain. The first one, my back will get stiff in the morning. The first thing, and the second one, my pain become very less when I start walking. So now you have a two scenario. One is morning stiffness, and the second one is when the person walks, he has a relief of pain. Okay. But when he sits, he has a pain. When he sits, he doesn't have a pain. But when he starts walking, he has a pain. So now we have a three scenario. Let's start from the one to identify the pattern. It is about the distal to proximal part. And the proximal to distal, which pattern is involving in your patient. So that pattern needs to be addressed first. More than 90% of the people directly start with the core stability exercise, core training. Let's go for a bridging, let's go for crunching, let's go for some transverse abdominis exercise. And at the end of the day, no, still my patient doesn't get repaired. The reason is you have chosen a wrong exercise prescription. So for those, just take a note, those who has a complaint of morning stiffness, we have to think about the pelvis along with the thoracic rotation component. The reason is when they lie down, the more energy is concentrated on the proximal part if they are complaining at the SIJ. Okay. And when they starts walking, what will happen? The transverse plane starts acting, the force is transmitted from the upper limb to the lower limb. So the person will get benefited. Here, we are not talking about any stenosis, any listhesis, or any inflammatory condition. Just the person has a simply morning stiffness. Okay, it also requires some mobility part that you have to address. But along with that, you have to more concentrate on a rotation component of a thoracic as well as the pelvic joint. Now, the second one, as I told you, the person has a complaint of pain when he starts walking. Okay. When he sits, he doesn't have a pain. In that situation, what you should look for, the person has a pain while walking. So first thing that comes in our mind is the person might have a stenosis. Fine. The person might have a prolapsed intervertebral disc. He might have a herniation of a disc. But before giving the label to your patient that you have a stenosis, you have a herniated disc, check the ankle range of motion, check the hip extension pattern. Why these two things you should check? When the person doesn't have enough ankle dorsiflexion, the person will not get the hip extension pattern because both are simultaneously connected with each other. When the person hits on the ground, the pelvis has to rotate posteriorly. Okay. Along with that, along with mid stance position, the hip joint goes into the extension. If any of the component is missing, the person has to pay the price in terms of excessive movement of the lumbar spine. The first thing, this is the common thing that we all think in our clinical settings, but think out of the box and see what about the thoracic rotation. When your patient goes into the heel strike pattern, he rotates his trunk. When the thoracic spine is not efficient rotation, okay, right rotation or as well left rotation, what will happen? The whole load will shift to the downside. So the lumbar spine has to take a more load to complete the ground clearance, to complete the mid stance to the toe of all whole the gait cycle. So the thoracic rotation is also important aspect. So next time when you have a patient with the complaint of lower limb, when he starts walking, he starts complaining of pain, go for the ankle dorsiflexion range of motion along with the extensor chain muscles, like you have to go for a gluteus, hamstring, gluteus, quadriceps, and go for the calf muscles. Simply do a calf raise and ask the patient to walk. If the pain subside immediately or after a few steps, then don't concentrate on a core training initially. Let the patient's brain understand about there has to be increasing in the load of the lower limb. So it is easy for brain to transfer from the upper limb to the lower limb. So if you understand all these patterns, that will help you to prescribe a proper exercise prescription. Otherwise, you will end up with the same exercise every day. So every patient is a different book. Every patient has a